Welcome to everyone to today's webinar on FCP. Our hashtag is First Contact Physio. If this is your first time to one of our webinars, I do hope you enjoy this experience. And we have run one before, and the details are on our ICSP. So these are our speakers, Larry and Amanda, and we also have Julie Blackburn, one of our professional advisors here as well, who's going to help with the Q&A. Now to Larry, who will introduce himself and share his slides.
So I'm relatively new to the CSP, so I've been in post roughly about 7-8 weeks now, so coming up to 2 months. And my role is as head of FCP Implementation. So there's been lots of excellent work that's gone on prior to me coming to the CSP, so by Sarah Withers, but also working closely with Amanda, who's kindly joined us today. And my role going forward for the next year is to try and support the uptake and implementation of FCP as much as possible in the UK, including Scotland, Wales and Northern Ireland. So what I'll do today is just go through what an FCP is and why it's important. I thought I'd start with just talking a little bit about new models of care. I didn't want to go into too much details or too much theory, where it's important to consider the role of the FCP role as the concept of it came out of some of the initial work for new models of care in the NHS, which was linked into the 5-year forward view, but even before that. And as a definition of what new models of care are, so new models of care can be a bit misleading because it implies that the model of care is always a new thing. And actually it's often more about thinking of things in a different way. So new models of care aim to support and stimulate cross-organizational change across local health systems to contribute to something called the triple aim, which is really around population health, so population health, cost effectiveness and quality of care, patient experience. And also aimed at making sure we provide updated evidence-informed whole systems approach to making sure that we're not just doing things for the current population and their needs, but also looking at the future and what the future healthcare needs are. So it's very much about being proactive in how we deliver services. And physiotherapists have got a really good background in that in terms of the biopsychosocial model, but taking that even further and talk about prevention and being proactive in the system to kind of help to reduce demand. So new models of care came out of a bit of necessity. So in terms of some of the funding cuts and going back a bit longer, so they were discovered as a means by which the English NHS can reduce demand and pressures on hospitals and general practices, whilst at the same time ensuring that quality of care for patients was improved. There were many different models of care. Multi-specialty community provider model was one of them. The concept of that really is about having multiple professional roles within primary care based around the need of the people rather than the job title itself or rather than specific tasks, which again helps to deliver that sort of population health model or approach that we are talking about. And the underlying logic behind it, really, so the underlying principle behind it is that by focusing on prevention and redesigning services, it is possible to improve health and well-being to achieve better quality, reduce avoidable referrals, hospital admissions and elective activity, and just unlock more efficient ways of delivering the care that we want to deliver, but also that the patients need. And having that multidisciplinary team is really important, and therefore multiple roles such as physiotherapists in primary care becomes a really core part of that. There are obviously other roles as well, but we'll focus on the role of first contact practitioners today. So what is actually an FCP? So first contact practitioners, in terms of our definition, are physiotherapists with advanced skills kind of working as the first point of contact for patients, providing expertise and an increased capacity in general practice, and providing patients with faster access to the right type of care. Often that care is around appropriate advice, appropriate assessment and advanced management. If onward referral is required, that can absolutely be provided, but a lot of the time it's around those really advanced skills. So the first contact practitioner in MSK is an advanced practice clinician who provides MSK services within primary care. It's basically taking these advanced clinicians at the front end of the pathway, but not just having an impact in that front end of the pathway, having an impact throughout the whole system. So you might, as you qualify and start to do more work start to hear the term systems approach or systems thinking or population health approach, but it's really thinking about the whole pathway. So actually, how do you link in primary care, community care, secondary care, and make sure that we're thinking about the system as we work, not just in our siloed environment that we're in. So this is quite a nice diagram in terms of how we think about population health. So it's about really looking at the whole of the population within, and you can segment that a little bit. You can look at it from a regional perspective, but within primary care, you might say, well, actually within a GP practice, what's the makeup of that GP practice in terms of their patients and their population? What type of support do they require? So every patient will need a certain level of support to stay healthy and to stay well. And then you might start to have those patients with the highest needs. And often the patients with the highest needs use up the most resources, but there are things that we can do to proactively support those complex needs. In the realm of musculoskeletal services, for example, you might have patients with multiple comorbidities. So not just arthritis, but other factors, and actually being bounced from one service to another is not necessarily the best way to meet their needs, and primary care really becomes an important place for some of these patients to be managed. And FCPs have a really important role in doing that going forward. I also wanted to just touch base a little bit, again, because you're qualifying and thinking about the kind of broader context. So FCPs are being implemented within the context of the long-term plan. Obviously, the long-term plan, which is also influenced by the COVID context that we're in. So you know, the ground is constantly shifting. But the long-term plan is quite explicit in relation to MSK services around some of the things that it's aiming to achieve, but also some of the things that we need to work towards. Some of those things are around making sure that the new models of care that we promote are promoting out-of-hospital services, trying to manage patients as close to home as possible, really providing that capacity for patients to be able to self-manage with appropriate support, guidance, social prescribing, where possible. It talks about increased support and promotion for personalized care. Personalized care is a whole topic in itself in some ways, but things like shared decision making, really think about that patient and their environment when providing support, rather than just thinking of them in terms of their joints or their body part that's affected. So thinking of them as a whole person, start to think about work and home and the broader factors and the wider determinants of health, which links into the population health narrative. There's also talks about being able to ensure that there are digitally enabled outpatient care to improve access to advice. So making sure where possible, patients can have access to the right type of advice and services. A real focus on population health and a focus on prevention. I think this is where the potential of first contact practitioners really comes into its own and is able to make a really significant difference, not only to the patient, but to primary care, as well as to the wider system, as we talked about a little bit earlier within the NHS. So something that you might become more aware of as you go through your clinical journey is the rapidly changing landscape for how the NHS is organised. So moving to primary care networks and the influence that primary care or GP practice is going to have in terms of delivering services to their population. You'll also come to realise that the NHS changes quite frequently. Within the next 5 to 10 years, hopefully there won't be that much change anymore. But you might find that things go from being very local to being quite national, and that shifting ground is always interesting. But it's important to maintain the principles as we go through that. And the final slide, really, a final thought, was just around the whole purpose of these things, these new models of care, the kind of roles such as first contact practitioners, primary care networks, is really around delivering high performing health systems. And it's really important we keep that in mind. There's lots of research, lots of evidence to underpin what is meant by high performing health system and what is required to deliver those high performing healthcare systems. So the broad themes are around, you need leadership and strategy. Might be beyond some of you right now, but actually leadership can be embedded throughout from the very early stages. So around the leadership side of things, so making sure there's quality and systemic improvement, making sure there's activities to kind of ensure there's alignment in purpose of the service that you're working in, but also shared decision making. So, you know, making sure that when you make decisions as a clinician, you're really thinking about the patient and making decisions together, not imposing. It talks about how we organize services. So again, primary care becomes a really important part of any high performing health system, which again emphasizes the point of having these multidisciplinary teams, and as part of that multidisciplinary team, making sure we have physiotherapists who have significant roles, and the evidence really is there and supports musculoskeletal services, which is where the focus is currently. And again, without laboring on the point, so whilst the FCPs are at the front end of the pathway, the integration to the rest of the system is of absolutely critical importance, and I'm sure Amanda will touch on that a little bit, and then in her slides around some of the kind of leadership skills required and the competencies and how you get there and what that entails. And then in the last column, improvement capability. So really, for health systems to be high performing, then there needs to be proactive approach to building quality. And again, this is where FCPs are really important in terms of being able to work collaboratively with systems leaders to ensure that our patients get the best. Is that okay, Steph?
Thanks, Larry. We have a question on the chat, actually. Is it possible to explain the difference between an FCP and an ESP? And is FCP purely MSK based? Amanda, do you want to take that?
Okay, so an ESP isn't a thing anymore. It's well, it is a thing, in as much as they do exist in the system, but the ESP is an extended scope practitioner. And they are people, but before the advanced practice programme came in, there were people in the system that were doing skill-based activities, clinical skills that were over and above the core of what physiotherapy was. Things like injection therapy, for example, is one of those things. Whereas now that it's not that they don't exist, they do exist. It's just that we call them advanced practitioners now. I shall be using the new language now. So as you grow up through the system, you will be looking to be advanced practitioners, but essentially you will still be advanced clinically as an ESP would have been. I can't remember what the other part of the question was.
It was about whether it's about FCP is around MSK exclusively.
Well, at the moment it is, but in the future there will be developments around other specialities, so watch this space.
Thank you. If anyone has any other questions, I can see something that's currently on the chat Q&A. How many years experience of working in the NHS do you need to apply for an FCP role? I think you're going to cover that in your...
I am, yes. I think I touched an answer to it earlier, but I'm going to cover that in a second.
Right.
Where you'll be completely
okay.
in a minute.
I'm just conscious that we've got people from all around the UK. So FCP roles in Scotland are called ACP roles. So there's slightly different terminology, but the principle remains the same.
Thank you. I think we'll take this opportunity to start Amanda's slides. And Amanda, if you introduce yourself, and then we'll take more questions. So please do keep them coming. Thank you.
Hello all, and thank you so much for being involved in this today. It's great to welcome a whole new workforce coming into being, and I'm really excited for you all to be able to be moving up through the system now. It's a very, very exciting time to be a physiotherapy student for the years ahead of you. So my name's Amanda Hensman-Crook. First and foremost, I'm a consultant MSK physiotherapist. But I am also the National Allied Health Professions clinical lead for Health Education England. So my role in Health Education England is about developing these training pathways that we're going to be talking about how to become an FCP, how you qualify to be that, and how you move forward from an FCP qualification through to advanced practice across all 4 pillars. Thanks, Steph. Next one. Okay, so it's a really good idea to explain what the Advancing Clinical Pathway is. So the Advancing Clinical Pathway is where you have got 4 pillars, which are clinical research, leadership, and management and education. And to be an advanced practitioner, you need to be signed off to level 7 master's level, clinical research, leadership and education in all 4 pillars. So that's the Advancing Clinical Pathway, and it's been held by Health Education England. There is the Centre for Advancing Practice, and that's where it all gets credentialed. And then once you become an advanced practitioner, you will be put on a directory eventually, so that everybody knows that that's your qualification, so it's easy for the employer to know that you are working at that level of practice. So it's important to know that an advanced practitioner is somebody that's working at an advanced level of practice. It's not a job title like that. There's a bit of a thing in the system really where you'll have heard of ACPs. When you go to the doctor's surgery, quite often you go and see the ACP nurse, and it sounds like a job role. Well, it's actually not a job role, it's actually a level of practice. It means that that person is qualified and working at master's level across all these 4 pillars. Thanks, Steph. So in terms of incremental career progression, in terms of the advanced pathway, so you've got the bit where you come out of college and you're a band 5 and you're learning about your skill set and getting used to working in the environments that you're working in as a physiotherapist in the different areas. And then when you decide to specialise, you become an enhanced practitioner, which is your band 6 MSK, if we're talking it as an MSK context here. And then you move into the advanced bubble, but as you can see, they overlap. So where FCP sits is at the entry level of advanced practice. I'll go on to explain that later on in detail, but then it's because the first contact practitioner, to be one, you have to be signed off to level 7. You have to be signed off to level 7 in the clinical level 7 area. It doesn't mean that you haven't started filling up your other 3 columns, your other 3 pillars, but it just means that you're not at level 7 across all 4 pillars yet. And until you get 4 pillars, then you're not an advanced practitioner. And then again, as you develop as an advanced practitioner, again, you can start moving into the consultant world, which is at level 8, which you have to start signing all 4 pillars off to level 8 PhD level. Thanks, Steph. So this is what it looks like. Okay, so when you're newly qualified and you're coming out into the world and you start doing your band 5 roles, some places, or a lot of places, still offer rotational band 5 roles. And I think that if you're thinking of going down the advanced practice route, as you go, as everybody is encouraged to do now as newly qualified practitioners. The reason for that is with advanced practice, it's not just about your speciality. It's really important to start building up a base of skill knowledge across all different areas. So the idea that you need to know about respiratory, you need to know about elderly care, you need to know about neurology, you need to know about pain management, all these things. Mental health is really, really important as well. And to see how that all integrates into the one speciality. So you can never just look at musculoskeletal on its own, because obviously we know there's a big relationship between musculoskeletal pain and mental health, for example, and that one affects the other from both directions. So it's really important to be able to look at that. And when you're looking at a musculoskeletal condition, you need to know whether it actually is musculoskeletal or is it actually the pain because of a neurological condition. So you need to know how to assess that and bring it into the speciality. And it's particularly with our elderly population as we're going on, I can't see any separation between frailty and MSK. And to look at the person as a whole person-centred care, and to learn to do that in your band 5 roles is absolutely key, because you're setting yourself a really, really important base as you travel along your career pathway. So roughly 2 years, when you do your 2 years, what we call a preceptorship in the Health Education England, you then might decide to specialise in musculoskeletal. So or as we said, touched on before, it might be a different, by the time you get there, it could well be that in primary care we've got other specialities that might be working as first contact roles in primary care. So you might decide to take up a band 6 in another condition and go down that route into primary care. And you work in primary care for roughly about 3 years. Now the reason, I know it seems like a long time, but to be advanced, you not only have to be advanced in your skill set, but you also have to have the experience, because you have to start developing your clinical reasoning skills. And to work in primary care, one of the absolute core skills that you have to have, and it's mandated to have, is to be able to do complex clinical reasoning up to a level 7 capability. So if we go back to the band 5 role, that's about how you gain your big base of knowledge. It's about how you're able to look at that patient, not just clinically, but also about their social situation and about their family situation, that person-centered care, and about how you can look at a person from that and identify, particularly like the red flags that to go down emergency and urgent care pathways, and to make sure that you drawing out of the conversation to make sure your patient's safe at home in case there's any safeguarding incidents and things like that, just so you can draw out conversation and clinically match it in a high level of capability. So once you've done your band 6, you can start the clinical capability sign-off to level 7. Now, the primary care clinical capability sign-off to level 7 is essential for first contact roles. I can't remember whether I've got this on my next slides, but yes, there we go. Thank you. There we go. So the clinical competence. So the really important thing is before you even start doing the primary care part of the sign-off, it's really important that you evidence, or you're able to evidence, that you're working clinically at level 7 MSK. So that gets signed off first, so that we know that you are working at an advanced level in your area of practice. Now, the reason we're doing that first is because when you go down the clinical sign-off for primary care, we're doing it the same way as the doctors do. So if they want to be a GP, what they have to do is get all their medical qualifications up to that particular level first, and then they can start doing the primary care work to be able to do that. And it's really important that we use this method of getting into first contact roles, because we work in primary care, and it absolutely assures the GPs that we're working in their environment, that we are at the right level of practice entering into primary care, and that we've got through the same rigour of training as the GPs have. So it's really important that we're positioning ourselves in that way as physiotherapists, as advanced, the beginning stages of advanced practice. Primary care is a bit of a funny area to work in. It's really different to working in secondary care or community care, because what you're seeing is undifferentiated diagnosis and undiagnosed conditions from the desk. So that's why we have to put all of this level of training going forward, really. To make sure that it's safe for the patients and that there's a governance around the whole thing. So that's why it's becoming standardised. So complex clinical reasoning to level 7 is really, really important, the next step. And there will be e-learning modules, and there'll be taught modules to do this, to show that you're working at level 7, complex clinical reasoning wise, and how you can integrate that into your practical work. There's 8 e-learning modules for primary care. That you can do that now if you want, it's fine. The 8 e-learning modules and the personalised care e-learning modules, if you're curious and you really fancy it, then you can log on to the Learning for Health website for Health Education England, and you can have a look at those. No reason why not. And also, here we've got FitNote training. So what's coming in now is that I know that we've got allied health professions FitNote sign off, but what we're looking for, looking to in the future, is the Department of Work in Health and Pensions, the actual DWP FitNote, so we'll be able to sign those off eventually. And we're working very, very closely in Health Education England with the DWP at the moment to design an e-learning sign-off for that, so that we've got the environmental training around FitNote training, so that we're actually spending more time keeping people at work rather than signing them off work. Okay, so I just wanted to say after that, this is a really exciting time for you guys moving into advanced practice. So even when you've done I haven't got a slide for this, but I just wanted to say that if you decide to go down this route, the really good thing about doing the clinical sign-off is that I know it's to clinical level 7, but we've pulled out all of the domains that are relevant to the advanced practice to sign off against all 4 pillars. So we've pulled out all those domains so that they'll be transferable across into a portfolio route to advanced practice, which is really important to know that there's 3 different ways to do your training for First Contact, and there's 3 different ways to do the continuation of training to become an advanced practitioner across all 4. So the difference is that when you're first of all clinical sign-off, that's the band 7 roles. And then when you move across and sign off against all 4 pillars, that's your 8A role in primary care, just so that you know. So the idea is that once you've done your clinical sign-off, that's the start of your advanced practice moving forward. And you can either do that by a portfolio route, which is a sign-off as you go along and you gain your bits and pieces from your various bits of evidence, which is going to be really explicit. There is an explicit document that will show you how you evidence that. There's a blended route, so you can do some taught modules at university to level 7, and then you can top up by doing your clinical sign-off with your supervisor. And then you've got the taught module as well. You've got an FCP module that you can do in a HEI, or you can do your master's degree to advanced clinical practice. So there's lots of different choices there. And it means that you've got lots of opportunity to do it, because we wanted to do it in 3 different ways so that everybody has the opportunity to do it regardless of what your home circumstances are and your work circumstances are, so that everybody's got the opportunity to become an advanced level practitioner. I think that's it from me.
I think there's a few questions around if you've already got an MSc. I think there'll be some people who are doing like a pre-reg MSc and whether that counts towards it. So I think there is a difference. Amanda might be best to touch on this, but there is a difference between level 7 and clinical level 7.
Yeah, so just because you've got an MSc or pre-reg MSc doesn't make you an advanced practitioner, because the clinical part of it only comes with experience on the job. You can't complex clinical reason without actually physically spending 3 to 5 years specialising in your area of care and building up around there. So you might have the master's. So of course, the fact that you've done a level 7 module might help in terms of signing off across some of the domains in a portfolio route for sure. But in terms of, it's the years under your belt for the clinical really that gets you to be the sign-off. So in terms of the advanced clinical pathway taught master's degree, for example, it states that you need to be at least 3 to 5 years within your area of speciality before you do the master's degree. And it's really largely because you need that clinical experience and that cross-system knowledge as well, knowing how primary care works, how community care works, and how the acute and trauma and the secondary care work, and how all the pathways join together. So it's your cross-system knowledge as well as your clinical knowledge, and that really doesn't come unless you've got the years under your belt.
And again, that separation between academic and clinical is really important. So having the pre-reg MSc is going to be helpful for you in the long term. But in terms of the clinical stuff, again, Amanda probably has better answers for this, but there are alternatives in terms of clinical roadmaps, clinical sign-off. So you may choose to go down an academic route to gain that clinical level 7, or you may choose to go down a less academic route, but more kind of work-based approach to be signed off for some of those competencies.
That's correct. But at the end of the day, in terms of even the sign-off and the academic, the core is exactly the same. It's no different. The credentialing to the clinical skill level at level 7 is exactly the same across every route. The fact that you have to do the primary care modules, exactly the same. It sits in every route, as does the personalised care module, as the fit note training. It's all the same. And basically the clinical sign-off is core. It's exact. It doesn't matter which way you do it, you still have to do the clinical sign-off. And in the FCP modules, that clinical sign-off's part of that course, that degree. The difference with that is that you come out with master's points. It's going to really help you if you decide to do the taught master's degree, because you've already got some of the master's points to help you get your master's degree at the end of the day.
Hi, Amanda, I'm just looking at the chat. There's a question quite early on about NHS experience. I just wonder whether you could touch on the difference in kind of experience in getting to that level 7.
NHS experience versus private experience, is that what I'm...
Yeah, I think so. The question is how many years
I
experience of
would
working?
seriously recommend that everybody, when they come out of university, has some experience in the NHS. The reason is because advancing practice, it's about working as multidisciplinary. It's about working cross system, and it's about that really broad base of knowledge. So when you're newly qualified, I think that getting a couple of years under your belt in the NHS, learning about how it all works, learning about having the opportunity on rotation to go and work in different areas of practice, in different sectors, really, really, really important for embedding. If you go straight into private practice, yeah, sure, you're still going to get clinical supervision and everything, but you're going to be missing out on a massive broad base of knowledge, and it's going to take you an awful lot longer to get to that point of being an advanced practitioner by not having that embedded knowledge at the beginning of your pathway and maintaining it throughout.
Just to touch on, there's another one just about mental health.
Yeah.
So I think you mentioned about getting experience in mental health. Is there any resources that you're particularly aware of?
Yeah, hopefully you'll be able to get an opportunity when you get into the NHS. Hopefully you get an opportunity to some people can have an opportunity to do mental health rotation, but you know, you're in the driving seat here. When you have your appraisal, that you sit and you want to learn some mental health experience, and you sit down with your supervisor and have a chat, and they should be able to accommodate you to gain that. If that's one of your things that you want to do, and it's something that you want to learn about in your appraisal, and you've set a goal, then they'll make sure that happens for you. So it's really good. But in terms of resources generally around anything clinical, I would recommend the e-learning for health website, Health Education. There's some fantastic modules you can do even now. There's nothing to stop you just because you're not qualified to go and access them and have a look.
There's a question asking if the pathway is the same in Scotland. Is it possible to share? I know that you're working in England, in Health Education England, but shed a line.
As of really strongly last week, okay, so the advanced pathway, the advanced clinical pathway, we're not calling it ACP anymore, we're calling it AP, advanced practice, not advanced clinical practice. The reason for that is we're aligning Health Education England with the other 4 nations, and that's really, really important. Because if you're in the other 3 nations, advanced practice already means that you're working to clinical to level 7 across all 4 pillars. Whereas in this country, advanced practice doesn't necessarily mean that. At the moment, it might mean that you're working clinically to level 7, but not across all 4 pillars. And that needs addressing. And for you guys coming through, it's just going to be normal. So yes, in effect, as you're moving through in terms of the advancing practice thing, it's going to be the same. But in terms of the clinical sign-off, we would be very happy for all 4 nations to have that, for sure. But at the moment, because we're Health Education England, we're currently developing it for England with the view to other nations having that too. So certainly, in fact, tomorrow I have a conversation lined up with the lead from Northern Ireland about this. So there is a lot of interest from the other nations, for sure.
Thank you. There's been a question about how to access the e-learning platform, and we'll share that email address, that web address in a follow-up email, so you have that. But just for your record, it's www.e-lfh.org.uk. And just to let you know, if you join with your either an NHS or your university, so your ac.uk email address, you get free access, and that's for across the UK. So so use your university or NHS email and not your private email to get that access.
Yeah, and then it's free to you. And also, if you're a numpty like me, all you need to do is Google Health Education England.
And we have a question asking what your opinions are on FCP using telephone appointments. And I know obviously with COVID, things have changed, but what is the business as usual and the sort of COVID response for that question?
Do you want me to answer that, Larry, or do you want to come in? I think I'll answer it. It's okay.
You come in the first and then I can come in after.
We can do it together, Larry. Let's do it together. We do it together. We work closely together, CSP and Health Education England, particularly me and Larry on a First Contact. So we do talk to each other. It should be reassuring to you all. Okay, so the telephone consultation thing's been really, really interesting. So and the video calls as well. So, you know, it's something that has been missing out of practice, and I think that Larry, being a youngster unlike me, will completely agree with that because he's more digital than I am. So in terms of, I'm a First Contact practitioner as well, within my consultant's role, and I've had a very, very interesting experience over COVID, because obviously all of my patients have been digital up until today, in fact. So what I have discovered is it depends on whether you're doing a consultation and triage or whether you're using it as a triage. So my job as an FCP is a consultation and a triage. Now that's very different, because the consultation and triage is really tricky because you can't see the patient at the end of the phone, which means that my consultations are taking longer than my face-to-face consultations, because I have to rule out all of the red flags. I have to check for any non-MSK problems. I have to check for frailty, and I need to check the whole person, the person-centered care. And I find that I have to get the right answers out of my patients, because they're not stood in front of them, you can't see them when they're at the end of the telephone. I have to ask the same question about 100 different times to make sure and double check that I've absolutely captured everything, to make sure that I'm not missing anything. And then the triage part's out there. But if you're talking about a straightforward triage, sort of when you're not doing an FCP role, and I think Larry will agree with this, then do you know what? I think it's underutilised massively, and I think that we've got quite a lot of learning from that, haven't we, Larry, really? And about sort of redirecting to online resources and things like that, because it is a digital area coming forward.
100%. And if you go back to some of the slides that I put on earlier, so actually one of the ambitions of the long-term plan, so your generation coming through, is for the system to be digitally enabled. So that will include video and telephone and so on. And actually what's happened during this COVID context is the previous barriers that we had have been massively changed and reduced. And, you know, in the future, I think there might be some stuff to look at the evidence for actual consultations going forward. But currently the evidence base is built on FCP being face-to-face. And so that's where we're at the moment. But I agree with Amanda in terms of the services that you go into will be much more digitally enabled. And I think you would be, I mean, there are student placements happening at the moment in some places online, and services which use telephone consultation. I think it's about making sure that those are well evaluated to actually see what the strengths and weaknesses are and when they're appropriate going forward. Because it will be emerging and growing and changing.
And I think it's important, really, if you're looking at patient choice, it's really important that patients have choices of whether they do it. I'm already in my FCP list. I have face-to-face appointments, but I have to, you know, in a day I'll have 20 face-to-face appointments, but I'll also have 8 telephone consultations, because some patients don't want to come in. And you'll find that maybe through that telephone call that you have with them, that you have to bring them and you have to persuade them to come in because you're concerned about them. But to be honest, for a lot of things, if it's a follow-up thing particularly, they don't need to come in for that, and it's actually a lot more convenient for a lot of people to speak to you on the telephone or have a video consultation rather than coming in if it's not a new diagnosis. So I think that moving forward, it's going to be a very exciting development, and this is your space, guys. This is up to you to innovate, and we're waiting for you to come through to teach us oldies a thing or two about digital work.
Can I just ask, there's a question as well around experience going at level 7, but somebody who maybe has got to level 7 in, say, neuro or respiratory capacity, can they still follow the FCP path?
Well, at the moment, the FCP path doesn't exist because I'm working closely with Health Education England, NHS England Improvement, and obviously the Chartered Society of Physiotherapy to see, you know, the roles coming forward of what you have to do for primary care. So when you're developing something new, so myself and another chap, Neil Landbridge, developed First Contact MSK to begin with. And what the first thing you have to do is to go and test the need for it in the system. So a piece of work needs to be done around these areas to see what the need is. So it's not just about the need in the GP practice. Of course, GPs love everybody being in their practice. If they had space to put us all in, they'd have us all in. But it's also about, by putting someone at the front of the care pathway, what does that look like for the rest of the care pathway? So we know with MSK, if we get the right person at the right place at the right time at the front of the care pathway, it makes the whole pathway efficient. So there's a bit of work that needs to be done around each speciality, which is being done, by the way. There are things developing in the background for this piece of work to be looked at, and particularly in areas of care. I happen to know of some pilots around paediatrics. I know some pilots around respiratory going on. I know some pilots around frailty going on at the moment. So at the moment they're pilots, but they're putting the feelers out to see if it's going to be beneficial to the system. So yes, they might be coming in the future. And certainly in terms of, if you're talking about the advanced practice route, then that obviously is open to everybody. And this clinical sign-off that we're doing, I'm working really closely with the APPN, the Advanced Practice and Physiotherapy Network. So we're developing it for MSK with them, the clinical sign-off. They're involved in all this. And we're taking out the whole core that's generic within that for primary care training, and for the other domains, the other three pillars, the leadership, education, and I always miss one out, research. Okay, so those cores are being pulled out so that the other speciality groups in that advanced practice network can start putting on the clinical speciality standards around it. So they've got clinical sign-off. So then they've got an opportunity then to be able to continue along the portfolio route in their area of speciality to advanced practice. It's a really exciting time. So by the time you get there, any speciality in physiotherapy should really easily be able to go through the advanced practice route.
Thanks, Amanda. We've got a question from Rebecca asking what resources you'd recommend for doing modules pre-qualification, and obviously there's the HEE e-learning platform with various modules. I also want to flag up the CSP website. So if you look at www.csp.org.uk/FCP, I'll put this in an email. There's some really useful resources. And if you feel that maybe what we're talking about now is maybe a bit advanced and you just need to understand a bit of a background, there's some really useful videos that Health Education England put together showing 3 different services in England. So I do encourage you to watch those videos and to look at the FAQs and the other resources. Is there any other modules or resources that could be useful for people that are pre-qualification?
For MSK, as soon as you qualify, I'd recommend looking at the MACP and the SOM, Society of Orthopaedic Medicine, and the I can't remember the
APPN.
And the APPN, which I've already mentioned. So all those 3, they've got masses and masses of resources for MSK, and they really encourage students and newly qualified to become really involved and to move through into these areas. And I'm more than happy to share resources with you at any time.
Not only to share resources, but actually facilitate your development through there. Whereas, think places like the MACP, I do wear an MACP hat, so I'm a bit biased, but where previously it's been quite only open to those who've completed a master's, now you can join as an affiliate member, an associate member, and kind of work your way through. So there's lots of opportunities, and the APPN are also very open, and as a SOM.
Yeah, as are the SOM, they're developing a route. They're learning from the MACP's journey, and they're developing something to create some parity in that as well. So there's lots of different ways to get your information. And if you're really interested in the FCP thing or whatever, I know that Larry and I, we don't mind being pestered by students too much, do we? I'm all for bringing, mentoring people, helping people through their journey. That's what we're here for. We're here to help you.
Thank you both, and also have to come in as the acronym police, because there's been quite a few that's been said, so we appreciate that there's been a lot of letters that have been thrown around that if you're not familiar with them, we are very guilty of that at the CSP, and I'm sure the HEE as well. But would it be possible, Larry, just to go through what those different networks are, just for anyone that's not familiar?
Yep, so the MACP is the Musculoskeletal Association of Chartered Physiotherapists. So the MACP is an organisation that's been long-standing, and it's steeped in evidence around kind of education standards in MSK services. So a lot of people who have become, who kind of developed, have completed postgraduate MSK masters, and often those are accredited by the MACP, not all of them, but a lot of them. APPN is now the Advanced Physiotherapy Practitioner Network. So it's really focused on, it was previously called the ESP network. So someone asked a question about ESP before. And it's really there to kind of promote and share advanced practice in musculoskeletal services. And SOM is the Society of Orthopedic Medicine. I know a bit less about them, if I'm honest. Amanda might know a bit more.
Well, they're kind of similar to the MACP, to be honest. But they just come from a different slant. So the SOM, they have got lots of resources. They don't have so many small courses as the MACP do, but they do level 7 modules in upper limb, lower limb, and spinal, and they do injection therapy courses. But they are developing other courses alongside. I think what's really good over the last year is that they've all come together. We've formed a partnership group, a physiotherapy, MSK physiotherapy partnership group. And what's really good is it's not just, we've also welcomed in osteopaths into that group and podiatrists to help influence us. We can do some learning across all of MSK. So there's a lot of shared learning now, whereas before they were quite separate. So I think that all of them will be very happy to reference the other and tell you where the strengths are of every, each of their own strengths and weaknesses, and send you in the right direction for what you want to do.
And also, this is a good opportunity to say there's some really good research papers out there where people have evaluated their own service. So if you want to choose FCP as your dissertation topic, or for anything else, there's some great resources. Our library, the CSP library, is more than happy to help with that if you need any signposting.
I've been rallying my regional health education England leads, and we had a call last week, and I was asking them if they could possibly go around all the universities to try and rally around to make sure that primary care becomes normal in your clinical placements.
And like Amanda said, don't let this be the only opportunity to speak to the people leading on this work. As part of the physio community, call on your mentors here and elsewhere. Find your links, build your networks. They are only going to benefit you down the line.
Yeah, and if you want to keep an eye on what's going on around FCP training and advanced, the advanced clinical practice sign off and advanced practice, then if you follow me on Twitter at Amanda Hensman, then you'll see what's going on.
So I'll leave that on screen while I thank my speakers, and thanks to Amanda, to Larry, and for Julie, especially for helping with the Q&A. There's been lots and lots of questions, probably the most we've had on a student webinar. So thank you, and thanks to everyone who's joined us today. It's been a great turnout.
Pleasure.
Thank you. Thank you for all coming. I really love having a chat with the students, even if it's just one way. Come and talk to me 2 ways sometime, please.
Yeah.
And you may find that you get some requests for students wanting to shadow you. So
oh yeah, come on, bring it on.
Fantastic.
Anyone in the Northwest, come over to my practice.
Great stuff. Okay, guys, it's been lovely to see you all. I keep forgetting to put my video back on. So it's been a pleasure. Like I said, we will email a follow-up with some of those links, and the video will be live very soon. And all I can now say is have a lovely rest of evening, stay safe, and we hope to see you on a future webinar. Thank you, everyone.
Thank you.
Bye, thank you.
Bye.